Go ahead.
This is a, I think I got the control.
Yeah.
This is an acute, this is a CT chest, soft tissue window, axial section of acutely patient presented. I would like to scroll the images first.
Go ahead.
Okay. So what I can see is a heterogeneous density area within the right perineum, having internal air foci within it. It is sort of loculated and it is not communicating with the peritoneal cavity. Uh, I'm going cranially in the images. Heterogeneous density area is seen within the inferior lingular segment of the left upper lobe along with soft tissue thickening. Normally, in such cases, I would like to see the bone window as well. Uh, in the abdomen, I can appreciate mildly distended gallbladder, dilated common bile duct. Sorry, ma'am, it's just the history of acutely presented, or is there any history of trauma?
No, there's no history of trauma. There's acute abdomen. Ignore the
Acute abdomen.
gallbladder and the CBD and the lung
Okay.
bases.
Yes, yes. So, and the rest of the abdomen, mildly prominent bowel loops are seen. Enlarged prostate is appreciated. In the urinary bladder, there is hyperdense focus within the dependent part of the bladder. Normally I would do the ultrasound to correlate for this whether it is movable or not to differentiate between a hematoma and the mitotic lesion of the urinary bladder wall. There is associated dilatation of the right proximal ureter as well. So
Ignore the urinary system.
okay. So considering the patient acute presentation, there are two possibilities of acute presentation: the dilated gallbladder with dilated CBD. The bowel loops, they appear normal. There is a calculus in the dependent part of the gallbladder. And inferiorly, the findings which I previously mentioned, I would like to reconsider those again. Um, So considering the presence of air within the right inguinal region, this can be a case of necrotizing fasciitis in the right inguinal area. And the dilated gallbladder with the calculus in it can also be cause of pain secondary to the acute cholecystitis. I would refer this patient to surgical department for further management and correlate my findings with the ultrasound as well. And if the patient is of is immunocompromised and diabetic, then this patient requires urgent management regarding the necrotizing fasciitis. I would alert the referring physician regarding this finding.
Okay, I'll give you the next case. Leave the mouse, please.
Yes.
Sorry, this is your next case. The patient has been in a road traffic accident.
Okay, ma'am. Mouse is with me. Ma'am, mouse, I'm not sure it's with me. Yes, I think it's with me. So this is a CT axial section, CT chest of soft tissue window, contrast enhanced images of a patient having road traffic accident. I would like to scroll the images first. I can appreciate some consolidation and collapse in the left lower lobe with the fluid-filled fluid density region within the lower part of hemithorax. Scrolling further inferiorly, the liver, visualized part of the liver and the splenic parenchyma appears normal. I can appreciate few left-sided fractures as well, and with associated pulmonary contusions as well. In
Very
my
good.
routine practice, I would have like to see the lung window to rule out any pneumothorax, as it is a case of road traffic accident, and bone window to look for in detail the fractures of the ribs and the vertebra and the bilateral scapula. However, in this given window, I cannot appreciate any major vascular injury, as the mediastinum, it appears normal.
Anything else you can see in the?
Yes, this fluid density area is concerning. I would like to check the coronal window to see its continuity with the infradiaphragmatic part.
I'm not giving you any coronals at the moment. If you
Okay,
can just
ma'am.
scroll through the axials and give me your impression, please.
Right, ma'am.
You're free to look at the portal venous phase if you think it can help you out.
I've got only one this arterial phase. I can select the other one also.
Yes, you can select
Okay,
the axial portal venous phase
okay,
if
ma'am.
that would help you out.
Okay, ma'am. And limit to the chest, or I shall include the abdomen as well in this, because
Whatever
it's,
you
I think,
want to
abdomen.
see.
Okay, ma'am. So this is the portovenous phase of the same patient. I would like to scroll to the top to see that fluid density area. That's located in the left hemithorax with associated subsegmental atelectasis in the left lower lobe. It can be secondary to the pulmonary laceration or localized hematoma formation, as this is a case of road traffic accident. And or as I mentioned earlier, I would like to um, uh, com to confirm it on the coronals to confirm whether it is abdominal viscous or not. However, on this axial sections, I cannot definitely make out the continuation with the viscera. But
Which
yes.
viscera are you thinking of?
It can be, ma'am, stomach I can separately appreciate. It can be part of colon, the transverse colon, splenic fracture.
Can you trace the colon for me?
Yes, ma'am. If as I'm
And
provided with that.
keep your arrow in the colon, starting from the rectum.
Okay, ma'am. Now I'm provided with the abdominal images, and starting from the rectum. So this is the rectum. Uh, and it is converted into sigmoid colon, and then the descending colon. It's right here, and taken it cranially. Here. So I think I can appreciate the colon separately.
So whatever you're looking in the chest, can this be the transverse colon or the splenic flexure?
No, ma'am, because I have traced it
Okay,
completely
that's fine.
separately.
Okay, I'll
Yes,
give you
ma'am.
the next case. Just leave the mouse.
Yes, ma'am.
Can you see the CT abdomen, a new CT abdomen?
Yes,
Okay,
yes, ma'am.
so this is an, you can take control of the mouse, and this is again a referral from A&E of a patient who has presented with acute abdominal pain and is in shock.
Okay, this is
Go
a
ahead.
axial section CT scan abdomen of a patient in shock. Ma'am, I'm trying to scroll. Yes. NG tube is seen passing through the esophagus. The soft tissue included window of the mediastinum appears okay. I can appreciate high density fluid within the abdominal cavity that is surrounding the liver and the spleen. The liver has got slightly irregular nodular margins, can be secondary to chronic liver disease. I can appreciate the gallbladder calculus. Mesenteric haziness is appreciated within the abdominal cavity. There is a large heterogeneous density area within the right lobe of the liver parenchyma. Normally, I should measure this lesion, and similar density, heterogeneous density area is also seen in the segment 8 of the right lobe of the liver. This can be representing laceration of the liver parenchyma.
No trauma.
Okay, no trauma. This patient presented acutely to the emergency department with shock.
Yes, with shock,
With shock.
with
Yes.
hypotensive shock. Yes.
Okay. Okay. So I'm looking at the rest of the organs. The small bowel, they appear collapsed. Inferior vena cava, it appears collapsed. And there is extension of the fluid into the pelvic cavity as well, the high density fluid, as I mentioned earlier. So normally for such patients, I would advise contrast enhanced CT for further evaluation, and considering the possibility of the liver lesion and the high density fluid that is in the abdomen, it can be secondary to the ruptured liver adenoma. And on contrast enhanced CT, I would like to further see the signs of the shock that includes the flattened inferior vena cava, enhancing adrenals, and the shock bowel syndrome. And emergent, I would pick up the phone and alert the referring physician of the finding and refer this patient to surgical team urgently for further management, as this is a case of shock and it requires urgent management.
I appreciate you telling me that this could be due to ruptured adenoma. Is there any other reason which you can think of in this scenario?
In this scenario,
Yeah, I mean to say, is there any other lesion, liver lesion, you can think of which can cause this scenario?
ma'am, hemorrhagic mets can be possible, or yes, considering the chronic liver disease and the nodular margins of the liver, it can be hepatocellular carcinoma.
Okay, let me give you the next case. Leave the mouse.
Yes, ma'am.
Sorry, I was muted. Candid, go ahead. This is a CT brain from A&E of a patient who has presented with altered neurological status.
Okay. Um, this is a CT scan brain axial section from A&E patient who presented with altered neurological status. I would like to scroll from top to bottom, as I do in my routine practice. I can appreciate mild prominence of the intra and extracerebral CSF spaces, and CSF density area is seen within the left occipital lobe. Few faint calcifications are seen within the bilateral basal ganglia, can be secondary to the age-related changes. The bilateral temporal horns of the brain appear normal. The midbrain
Sorry,
and
what did you just say? I missed it. What was the last
the
statement you
temporal
made?
lobes, ma'am, I was commenting on the temporal lobes that no significant finding is there. And the
Okay.
infratentorial part of the brain, it appears normal. There is a focal swelling, soft tissue swelling anterior to the left frontal bone, and it appears hyperdense on this plane images.
Okay. What else
Uh,
you can see?
yes, ma'am. I'm reviewing the images further again, and I can appreciate that there is mild preseptal cellulitis involving the left orbit.
Ignore it. It's
Okay, ma'am. So I'm reviewing this brain findings again to look for any other important acute finding in addition to the age-related changes of the brain parenchyma. And the hypodensity that I noted can be secondary to chronic encephalomyelitic changes, secondary to previous infarct in the left occipital lobe. Um,
So how would you like to conclude this case, candidate
yes,
one?
ma'am. I'm not convinced about the neurological findings presented with the patient and the CT findings. So just want to review the CT once again
Do you want to
to
do anything else?
there is area of hyperdensity within the subarachnoid spaces in the right um, posterior parietal lobe.
So what do you do in your routine practice when you have suspicion?
I changed the windows.
So
I
can you take the next axial non-contrast
Okay, ma'am.
and give me your comments, please?
Yeah, ma'am. Um, Normally, for such patients, I would see the signs of any dural thrombosis, and there is a slight hyperdensity along the left tentorium cerebelli. The right tentorium cerebelli, and so considering the findings of a neurological deficit and the right-sided hyperdense tentorium cerebelli and possibility of this hyperdensity along this hyperdensity concave shape hyperdensity is noted along the right posterior parietal lobe. So this is the case of subacute. This is the case of subdural hematoma along the right posterior parietal lobe with the right-sided subarachnoid hemorrhage. I would pick up the phone and inform the referring physician of the findings and alert and refer this case to neurophysician for further evaluation.
Okay, very well done, candidate one. So your Viva is over. I'll switch to candidate two. If you can
Thank you,
leave the
ma'am.
mouse.
Thank you,
Yes,
ma'am.
and no worries. Candidate two, if you can.
Assalamu alaikum, ma'am.
Walaikum salam. Just let me bring in your case.
Ma'am, if you can switch off the control of my mouse.
That doesn't matter. Once the candidate two asks, it would be fine. Okay, candidate two, is anyone else unmuted apart from candidate two? Okay, that's better. Uh, Candidate two, this is your case of CT brain. I'm not giving you any history at the moment, and you are free to scroll both sets of windows and give me your findings. Please, your time starts now.
Can you hear me, ma'am?
Yes, I can. Oh, just wait. Just wait. Stop, candidate one. You are supposed to,
I just now clicked on the screen.
yeah, click on the screen, not on the bottom, because it went to the next case. And there would be a sidebar at the side. Just wait. Let me try to.
Actually, I cannot see this sidebar.
Okay, just wait. Let me help you out here. If you can leave the mouse, let me see what I can do here. Let me. Is the sidebar visible to you now?
No, ma'am.
It should be if the candidate one was doing with it. Are you on a laptop or not?
Yes, ma'am, I'm on my laptop.
So can you see my mouse moving around? Can you see my mouse? Can you see my
It's not
cursor?
moving around, ma'am. Yes, ma'am, I can see your cursor, but it's not moving around.
Is it the same for the rest of the candidates? Okay, sorry. Okay, sorry. I was not sharing. Can you see my cursor now, please?
Yes, ma'am, I can now. And I can see the
Fantastic.
sidebar as well.
Okay, great. So let me restart your time
Yeah, sure, ma'am.
and start now.
Okay.
Click on the sidebar, and you can use the arrow buttons up and down or use the mouse, either of them, but stay on the sidebar, yeah?
Okay, ma'am. So I've been presented with a CT scan of a brain of a patient whose history has been withheld. I'll be scrolling from bottom to top. Oh, what's happening?
Candidate 1, leave it, please. Leave it, please.
Probably when I use the mouse key, the keyboard keys, it starts to happen.
You're using the right or left or the up and down?
I'm using the up and down.
I don't know. It shouldn't happen that way. Use the mouse then. I'm also using
Okay,
up and
sure.
down. And when I'm using
Yeah.
up and down, it only goes up and down. It should not go on the next case. Just check again. Otherwise, I'll scroll it for you.
Okay, I'll then use my mouse and I'll use the sidebar.
Yes, please.
Sure. So I'll be scrolling from top to the bottom. The first striking abnormality I could appreciate that there is an isodense area which is appreciated in the right high parietal region. And I can also appreciate two burr holes. Might the patient has been some history of surgery for that. As I scroll down, this isodense area is causing compression of the brain parenchyma significantly, causing mass effect with the contralateral subfalcine herniation and compression on the ipsilateral lateral ventricle, which is effaced, and it shows quite significant midline shift. I cannot appreciate the body of the occipital. I can appreciate that the frontal horn and the body of the right lateral ventricle is significantly compressed, and I cannot appreciate the occipital horn here. As I scroll inferiorly, there is non-visualization of the ipsilateral temporal horn as well. The contralateral cerebral hemisphere, both and also the bilateral cerebellar hemispheres, they look unremarkable. So a large I would like to evaluate for any, I would review the clinical notes for this patient. So a large isodense area. I can also appreciate that there is an ill-defined hyperdensity which is appreciated in the right frontal region as well, which is causing compression on the temporal lobe as well, causing effacement of the Sylvian fissure. So
Would you like to do
this
anything
is,
while you are scrolling such a CT case in your routine practice?
I would change the window and to see if there's any underlying bony fracture or not.
Other than the bony fracture for the
I
blood?
would also measure. I would also measure the HU.
Okay, check the others, next series, which has just a different window. That's all. Not the bone window, but a different window. Go ahead.
The axial non-contrast one, yeah?
Yes, yes, please.
Okay. So I would see the subdural window for that in my routine practice. So in this provided window, I can
Sorry, I didn't
appreciate this
get
length.
what you said. What did you say? You will review what? Sorry.
I will review the same which is in subdural window just to confirm my
Okay,
findings.
okay.
Yeah. So I can appreciate that there is a large significant a subdural hematoma which is outlining the right frontal, parietal and temporal lobes and causing significant mass effect with subfalcine herniation. I would urgently inform the referring physician of my findings regarding this subdural hematoma which is causing herniation and would review the clinical notes of the patient as well and urgently involve the neurosurgical team for the evacuation of the subdural hematoma.
Okay, thank you. Leave the mouse. I'll give you the next case. So this is a female patient who has come with low hemoglobin, okay?
Okay, ma'am.
And this is the CT which has been done for this patient due to drop in hemoglobin. You are free to scroll.
Okay, ma'am. So I've been presented with a CT scan of abdomen of a female patient who has presented. Sorry, ma'am, just forgot. Just the history has got. Can you please, ma'am, repeat the history?
No, nobody will repeat the history. It's your luck. This is practice. Don't worry about what you do right
Yeah,
now. All this will be your
yeah.
learning points. If you have forgotten the history, you'll remember now at the end, you will remember it for your next Viva. That's fine. Go ahead. You'll know once you
Okay.
scroll.
Okay, so I've been presented with CT scan of the abdomen of a patient, of a female patient. I'm scrolling from top to the bottom. The first abnormality which caught my eye is a faint, ill-defined hypodense which is appreciated in the liver parenchyma in segment 5. As I scroll down inferiorly, bilateral adrenals look normal to me. The spleen shows raciform sort of enhancement on this arterial phase. As I scroll down, bilateral adrenals, they look normal. The pancreatic tail, body, and head also looks normal. I cannot appreciate any pathology within them. The stomach, however, is collapsed and shows
Ignore the stomach.
enhanced. Okay, ma'am. Uh, I'm scrolling inferiorly to see the gut, which is not dilated at the moment. Yeah, so I can appreciate that there is a blush of arterial contrast within one of the bowel loops. I want to trace whether it's probably the large gut because I can see the continuity of this part of the bowel along the left side. So it's probably transverse colon. I can see a blush of contrast over there.
Can
Uh,
you now trace the whole colon for me, please?
yeah, I'll be going down and okay, so this is the anal canal, then the rectum.
Keep the arrow on the colon
This
as you're
is the
tracing.
rectum. Yeah,
Good.
yeah. Oh, I have to go up. Yeah. So this is the sigmoid colon. The sigmoid colon is collapsed and shows this is the splenic flexure. The splenic flexure goes here. There is mild prominence of its caliber. However, it's not pathologically dilated. This is the transverse colon. So this is the transverse colon basically. Yeah, so the blush of contrast was seen within the transverse colon here
Okay, go to
on
the
the arterial
portovenous
phase.
phase.
So on the protovenous phase, I am now scrolling to see. Yeah, so there is basically more contrast, the presence of there is significant contrast blush over here, which has progressively increased since the arterial phase. So the patient has presented, if the patient has presented with anemia and abdominal pain, this could be likely representative of a small bleeding polyp in the transverse colon, which has led to anemia, or it could be due to some angiodysplasias. But for this purpose, I would like to review rest of the gut as well. And I would inform the referring physician on my findings urgently regarding this bleeding point in the transverse colon of this patient and would refer the IR team for further management as well
Okay,
as
so
inform
you've
the
so
gastro.
you've so you've got an amazing IR team in your department, okay? And they did
Mhm.
this angiography. Can you give me some comments about this angiography?
Okay, are these scrollable images? Can I scroll them?
You'll have to check.
Uh, yeah, these are scrollable.
Good.
Okay, so I can appreciate that the catheter angiogram has been done and the SMA has been catheterized, which is opacifying the jejunal branches of the SMA. And I can appreciate that there is there is a region of significant contrast blush noted
Good.
in the jejunal branches, which is appreciated over here.
Can you look
So
at the
I would,
next series, which is
yeah.
provided to you?
So this is SMA post embolization. The embolization has been done regarding this bleeding point, and I can appreciate now that there is no contrast blush, which is appreciated over here, or in the previously cited area of abnormality, which was the jejunal branches of the SMA.
Okay. So you can
So
leave
it
the
has been
mouse. I'll give
embolized.
you the
Yeah.
next case. Yeah.
Yes, ma'am.
So again, this is a CT brain presented from A&E, altered neurological status.
Okay. So I've been presented again with a CT brain axial non-contrast study. I'll be scrolling from top to the bottom.
The patient has a neurological deficit on the right side.
Okay. So the patient has presented with neurological deficit and has been referred from ER. I am scrolling from top to the bottom, and the bilateral cerebral hemisphere, the centrum semi-ovale, both in the frontal and the parietal lobes, they look normal to me. I The bilateral lateral ventricles, they look unremarkable. Uh, there is no evidence of any ventricular dilatation. Bilateral ciliary fissures, they also look normal. Uh, Bilateral temporal lobes are also normal. However, I can appreciate that there is a faint hyperdensity which is appreciated along the right sigmoid sinus. It could be projectional, but
Ignore
I
the
would
sigmoid
like to
sinus.
review. Okay, ma'am. So I'm scrolling inferiorly. Uh, to see if there is any other pathology. Uh, the There is no evidence of midline shift. The brainstem structures look normal. There is faint hyperdensity within the basilar artery, but no evidence of any area of infarction or gray white matter differentiation is appreciated. Uh,
Do you remember the history I gave you?
the patient presented with neurological deficit and right-sided symptoms were there.
Yes, good.
Yeah, so I'm now looking at my review areas. Uh, I could not appreciate any significant pathology in first scroll. All the systems, they look unremarkable. I am still worried of the fact regarding this hyperdensity within the basilar artery.
No, it's not. Ignore
Uh,
it. Once the examiner has said ignore it, ignore it. Yeah. So
okay.
what will you write in the report if you cannot find any acute finding?
If there is no acute finding and the patient has presented with right-sided symptoms, then I would ask for a DWI imaging, MR with DWI imaging, or a CT scan, brain CT scan with perfusion study could be done to see if there is any evolving sort of ischemia which has causing symptoms on the right side of the patient, which might be it's a sort of like an evolving ischemia.
So the MRI could not be done, unfortunately, in this patient. but the patient still had persistent symptoms, and this is CT about 1 to 2 days later. Can you scroll and give me the findings, please?
Okay, ma'am. Uh, so I'll be scrolling from top to the bottom once again. Uh, I can appreciate the skull looks normal to me. Bilateral cerebral cortices in the parietal lobes, they look normal. No evidence of any white matter abnormality appreciated. Centrum semi-ovale also looks normal. Uh, no evidence of any ventricular dilatation appreciated. Uh, the sulci gyri are maintained bilaterally. The Sylvian fissures are normal. As I scroll inferiorly, I'm uh, bilateral gyrus rectus, they look normal. Uh, I want to see the left Sylvian fissure, it's fine. No evidence, I cannot find any subdural or collection or any evidence of subarachnoid hemorrhage bilaterally. There is no area of significant loss of gray white matter differentiation. Uh,
That's fine, candidate 2. That's okay. Okay. So I'll go to candidate 3 now. And as I said, I'll give all the feedback in the end here. Candidate 3,
okay,
are you
ma'am.
there? Are you ready?
Yes, ma'am.
Okay. So candidate 3, this is your patient. A&E case, acute abdominal pain.
Yes. Should I ask for the control, ma'am?
Yes, please.
Yes, ma'am.
Mm, so go ahead. Can you scroll? Just check. Click on your screen once. Yeah,
Ma'am, I
okay.
have, yes, ma'am. Okay. Uh, axial section contrast enhanced CT scan, lower chest and abdomen of a patient who has presented with history of acute abdomen. I would scroll through all of the available study and then describe the findings.
That's
I can
fine.
see that there is evidence of free air in the upper abdomen. And I cannot see any dilated gut loops, the liver, gallbladder, and the kidneys do not show any abnormality. And there is no lymphadenopathy. The Foley's catheter is seen within the urinary bladder. I am now scrolling back. There is an abnormality involving the region of sigmoid colon, and I can see that there is also free intraperitoneal air in this region. And I'm tracing the large gut. I'm tracing the region of the transverse colon. This is the transverse colon.
Can you concentrate on the findings you just saw in the pelvis and interpret the findings, please?
Yes, ma'am. In the region of the pelvis, I can see that there is abnormality involving the sigmoid colon. I can see there is wall thickening and enhancement, and there are air attenuation foci that are seen outside of the gut lumen, suggestive of pneumoperitoneum. I'm looking for any collection. I cannot see any focal peripherally enhancing collection, and rest of the large gut is not, there's no evidence of obstruction. And uh, for these imaging appearances, I would, as the patient has presented with acute abdomen, I would also look at any previous history or imaging, and I would be considering acute diverticulitis that has with wall perforation
There
and
is no
free
history of
intraperitoneal air.
diverticulitis. Yeah, and we cannot see any
Yes.
diverticular at the moment. What other possibility can there be for these imaging features?
Uh, this is uh, this is perforation. There could be, I cannot see any definite evidence of mass
Okay.
or diverticulitis is one possibility that has been ruled out. There is a mass is another possibility that can uh, cause a wall perforation, and other than that, any uh, inflammatory bowel disease is a possibility, but that would
Okay,
be in
fair
a
enough. What will you do next?
in this case, I would urgently discuss the findings with the referring clinician, and I would pick up the phone and urgently inform the surgical team of perforation and free intraperitoneal air. And this might would discuss regarding laparotomy, as it is a surgical emergency.
Sorry, I was muted. Candidate 3, this is
Yes, ma'am.
11-year-old pediatric patient presented with left orbital swelling. Go ahead.
Yes, ma'am. It is not. Yes.
Can you scroll? Yeah,
Yes.
good.
Yes, ma'am.
Okay.
Okay. Uh, Axial section CT scan of an 11 years old patient who has presented with the history of left orbital swelling. I would be scrolling all of the available study and then describe the findings. Uh, in the brain parenchyma, I cannot see any focal abnormality or any loss of gray-white differentiation. The fox is in midline, and the lateral ventricles are not dilated or do not show any fluid levels. And the extra axial CSF spaces so far do not show any abnormality. The region of the sylvian fissures and the brainstem, no hyperdense MCA or basilar artery seen. I can see that there is an abnormality involving the left orbit, and there is a left proptosis of the left eyeball. There is a preceptal soft tissue swelling, and I can see that there is uh, um, well-defined area at the medial aspect, and I can see that there is also abnormality involving the left maxillary sinus that has been opacified, and uh, okay, so there is opacification of the left maxillary sinus, and that opacification is also extending to the region of the maxillary ostium and also left ethmoid air cells. And there is an abnormal area at the medial aspect in the extraconal location in the left orbit, and it is giving peripheral enhancement and appears well defined, causing displacement of the medial rectus muscle and significant proptosis of the left eyeball. And looking in the region of the orbital apex, I cannot see its extension into the orbital apex or any abnormality of the cavernous sinus. Uh, and I'm now I'll be looking for any intracranial extension evidence. There is also opacification of the left frontal sinus.
Ignore
In
that.
the
Can you summarize the
okay,
findings you have told me?
Uh, in this case, my primary differential is an infective etiology that has started from the paranasal sinuses, and there is possibly a breach of the lamina papricia, and the infection has caused a subperiosteal abscess in the left orbit. In my routine practice, I would also look at bone window images to assess for any bone erosions or destruction. And in this case, I would discuss the findings with the referring clinician and would urgently inform the ophthalmology team of these findings. This requires urgent drainage of abscess.
Okay, candidate 3, I'll give you the next case. Just wait. Huh?
Yes, ma'am. Should I scroll, ma'am?
Can you see the acute abdominal CT? Yeah, okay.
Yes, ma'am.
Yes, so this is an elderly patient presented to A&E with acute pain. Go ahead, you can scroll.
Yes, ma'am. Ma'am. Yes. Axial section CT scan, contrast enhanced, of an elderly patient who has presented with history of acute pain. I would scroll through all of the study and then describe the findings. I can see that there is abnormality on the left side, and there is a retroperitoneal abnormality, and it has caused anterior displacement of the kidney. There is also abnormality involving the abdominal aorta, and it appears dilated. I cannot see any filling defect within the aorta. Is after the aortic bifurcation, and that abnormality on the left side is continuing into the pelvis along the iliac vessels, and in the pelvis the urinary bladder and the region of the rectum appears normal. I would go back to that abnormality. So there is high density retroperitoneal region, and that has caused also thickening of the Jarota's fascia, and I can see that there is an area circumferentially present along the abdominal aorta, and abdominal aorta is significantly dilated in the just in the infrarenal part, and there is displaced calcifications of the aortic wall also seen, and there is I'm looking for any uh, there is also a contrast blush seen along the anterior aspect within this non-enhancing part that is contiguous with the wall of the aorta, and I'm looking for the extent of this high density uh, collection that is predominantly located at the left side in the retroperitoneal space, and I cannot see any intimal flap within the aortic lumen, and for these imaging appearances, I would look at any if any previous imaging is available. This is most likely a case of ruptured abdominal aortic aneurysm, and there is active contrast extravasation with retroperitoneal hematoma formation. In this case, I would discuss the findings with the referring clinician, and I would pick up the phone and urgently inform the interventional radiology team of these findings, as there is active bleeding. The patient might be in shock, and after acute management of the shock, I would discuss regarding angiography and further management.
Okay, candidate 3, just leave the mouse. I'll give you the next case, yeah?
Yes, ma'am.
Okay, candidate 3. So this patient, again from A&E, the surgeons have called you and are requesting the CT abdomen because they think that this case is not acute appendicitis as per
Yes,
their
ma'am.
assessment. Go ahead and tell me, what do you think of the CT abdomen?
Yes. Axial section CT scan, contrast enhanced with the history of suspicion of acute appendicitis, a patient with history of acute abdomen. I would scroll through all of the available study and then describe the findings. I cannot see any parenchymal lesion, liver, spleen, adrenals, pancreas, and kidneys appear normal. Abdominal aorta, inferior vena cava. I'm looking at the gut loops. So far, the gut loops do not show any wall thickening or any lesion. No enlarged lymph nodes are seen. There is a streak of fluid on the right side along the ascending colon, and also there is a mesenteric fat stranding in this area. And further, I can see that this is extending into the pelvis, and the sigmoid colon and the rectum do not show any definite abnormality. Urinary bladder, Foley's catheter has been placed. Therefore, I am going back to the region of abnormality. There is thickening in the region of so this is a blind ending loop here that appears thickened with surrounding fat stranding, and now I will be looking at the cecum that also appears thick walled and with a streak of fluid, and the ascending colon apart from the cecum does not show any wall thickening or any mass. I would be looking at the region
So
of the
what is your
terminal ileum.
conclusion, candidate 3?
My primary differential in this case is inflammatory etiology with acute appendicitis that has involved the cecum with inflammatory changes in the cecum. And
So what
another
will you tell
possibility,
surgery?
this would require surgery due to acute appendicitis.
No. What is the inference you're giving to surgery? What is the report you're giving to surgery? Surgery team, I mean, surgical team.
Ma'am, I would keep acute appendicitis with inflammatory changes in the adjacent part of cecum as my primary differential. Other possibilities would be infective etiology if there is any previous history, or like tuberculosis or amoebiasis could affect this region. And
Which
other
region?
terminal ileum is not involved, therefore I am keeping it as less likely differential tuberculosis.
Okay, thank you. Candidate 4, do we have the candidate 4 now?
Yes, ma'am.
Okay. Thank you, candidate 3. I'll
Yes,
go to candidate 4 now.
thank you.
Candidate 4, can you see the axial images of the CT brain?
Yes, ma'am.
So this is a young patient involved in road traffic accident. Your time starts now.
Okay. So I've been provided with multiple axial images of the CT scan brain non-contrast of a patient who was involved in a road traffic accident. I will quickly scroll through the images and then begin my description. So on the first scroll, I can appreciate that there is a soft tissue hematoma noted along the right parietal region, along with an extraaxial collection, an extradural hematoma along the right frontal region. Apart from that, I do not appreciate any midline. There is mild midline shift towards the left, but there is no parafeld sign herniation noted, and lateral ventricles appear to be normal.
Can you please again tell me which type of hematoma is this? Which type of hematoma are you talking about?
Sorry, ma'am, it's a subdural hematoma. It's a crescent-shaped extraaxial collection.
Okay. Anything else?
I would like to review the bone window.
Go
as
ahead,
well.
take the bone windows.
So on the bone window, I appreciate that there is a fracture along with a depressed fragment at the same site. I would, and there is depression of the bone, so this is a surgical emergency. I would urgently inform the neurosurgical team for evacuation of this hematoma as well as the bone fragment.
Okay, good. Leave the mouse. I'm going to go to the next case.
Okay, ma'am.
Candidate 4, can you see the X-ray abdomen?
Yes, ma'am.
So please
So
comment on the X-ray abdomen first. Yeah.
I've been provided with an X-ray abdomen of a skeletally mature patient in which the most striking abnormality, I can appreciate that there are multiple gas-filled dilated small bowel loops throughout the abdomen. I also appreciate that there is a large bowel loop which is dilated and fluid-filled in the left hemiabdomen. There, I'm looking for any.
Okay, regarding the colon distension,
Yes, ma'am.
would you like to elaborate this further, please?
So I appreciate that there are hostile markings within it. And apart from that, it seems to be arising from the left lower abdomen and extending towards the right. Um,
What is extending from the
the colonic loop, which is extending from the left hemipelvis, is
can you
extending up
can you
towards the.
can you use the cursor and show me which bowel loop are you talking about, please?
This one is the large bowel loop.
Can you click on your screen once and then show, because yeah, now I can see. Yes. So what is this part of the colon? What did you say?
So it appears to be ostrated.
Yeah.
So I would be thinking of the cecum, that it is arising from the left flank and extending towards the right side. This is like in keeping with a distal large bowel obstruction, because I can appreciate both the large bowel and as well as the small bowel, and I do not appreciate any free gas. However, in order to be sure, I would look at the lateral decubitus femur if available.
Okay. Is there anything
Um,
else you would like to see other than the radiograph?
if there's a CT of the patient available.
Okay, leave the mouse. I'll give you the CT. Candidate 4, can you see the CT abdomen here?
Yes, ma'am.
Okay, go ahead.
So again, I'll quickly go through the images and then begin my description. Um, so this is the same patient whose X-ray I previously saw. And again, there is redemonstration of multiple dilated small as well as large bowel loops. My first instinct would be to look at the hernial orifices. They are intact. So going up, I can appreciate that there is some pleural effusion and basal atelectasis noted. However, I would confirm them on the lung window. The nasogastric tube is in situ. Um, there are air fluid levels noted within the large bowel.
So based on the CT images,
Yes, ma'am.
how do you, what is the etiology of this bowel morphology, which you saw on the X-ray and on the CT? Can you pin it down?
Ma'am, it appears to be, I would, in my normal practice, I would confirm it on the coronal window, but appears to be.
No,
First-
in exam, you will not get the corner windows. Can you trace the bowel on the, you saw the dilated descending colon, isn't it?
Yes, ma'am.
So keep your arrow on the descending colon, trace it, and you'll find the etiology. Tell me the etiology here. Descending.
Uh, there's some lag, it's not moving.
Don't worry about the lag. Take your time.
I'm going back towards the large bowel. There appear to be some hyperdensities noted.
Can you show me the large bowel, Candid 4, with the arrow? The dilated large bowel which you are tracing.
This is the rectal sigmoid, and going back up, now it's moving. So there is a segment of thickening in the descending colon, which I can appreciate with some very lesional fat stranding. So keeping this in view, this would likely represent a colonic mass. And next, I would also look at the lung window to confirm if there's no pneumoperitoneum, and I would then refer this patient to the colonoscopic to the lower GI MDT for further colonoscopic biopsy of this mass and CT staging.
Okay, leave the mouse. I'll give you the next case, yeah? So this is your next young female patient, 6 weeks pregnant, and she has dense left hemiparesis, okay? This is your CT. Go ahead, scroll it and give me your interpretation.
I'm having a quick scroll through the CT brain images. So as I go through the images, I can appreciate that there is some hyperdensity noted within the right hyperparietal region in the interparenchymal area with some hypotensedema surrounding it. Apart from that, I can also appreciate that there is sulcal effacement overlying the parietal lobes. Looking at
When you are
the
describing the findings, it is always a good way to put your cursor and point out the findings which you are describing, yes? It becomes easier for the examiner to assess.
So I can also appreciate that there's some sulcal effacement.
Which side are you
However,
talking about, Candid 4?
on the right, along the right parietal,
Okay.
there is generalized, but not along the right parietal, I can appreciate it most.
Okay.
And since I saw an intraparenchymal hyperdensity likely in keeping with the bleed, so I'm looking for any other subarachnoid hemorrhages or any other segmenta. But I do not appreciate any. Next, I would be looking at the dural venous sinuses, as this may represent venous infarct of hemorrhage. So there is a hyperdensity noted within the left sigmoid sinus. and possibly the right transfer sinus as well. So I would alert the referring physician and would suggest an MRV to further assess this
Okay,
patient.
candidate 4, can you just go to the images where you showed me the positive findings, please?
I'm at the top of the scan, this one.
That's fine. That's fine. Leave the cursor for a second. Yeah. So this is 24 hours later. Another CT was done. Can you please make comments on this, please?
So scrolling from top to bottom, I can appreciate that there is redemonstration of that hyperdense bleed in the right parietal region, which has slightly increased in size.
Tell me about any additional findings, please.
And this is a post-contrast study, so I can appreciate that there is some leptomeningeal enhancement noted along the right parietal lobe as well. So this has likely progressed to cerebritis, and I would,
Are you scrolling?
so ma'am, I would just alert the referring physician of these findings.
So you saw the right-sided changes and you are thinking, keep scrolling.
Ma'am, I was thinking that this is a hemorrhagic infarct that
Can
had
you
been
look at, so is there anything which supports your provisional diagnosis? Take a look at the coronals. So when the examiner thinks that he needs or he or she needs to give you additional sequences to make the diagnosis, he or she will. But if the examiner thinks that it can be done on axial images, they will provide you only with the axial images. So now I have given you coronal because I think it would help you. So can you give me any additional finding and then we can conclude the Viva?
Ma'am, again, I think there's a hyperdensity noted within the left transverse sinus, but I'm not sure about it.
Is this a plain study? You're talking about hyperdense transverse sinus.
Sorry, there's non-opacification of the transverse sinus on the left side. This is a post-contrast study.
So you mean both of the transverse sinuses are not opacified?
And this one.
Okay, anything else? Okay, this that's fine. That's fine, candidate 4. You can leave the mouse. Yeah.
Okay.
So we will go to the feedbacks. First of all, let me say to all the 4 candidates that you guys did extremely well, all of you. Okay. It's not easy to give the Viva on a hot seat. Okay, it's not easy to give the Viva on the hot seat. And perhaps the rest of the candidates who are at the moment observers might think, no, 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 this is very obvious. But even when they will come on the hot seat, it gives you a different sort of dynamics. And it's difficult to pick up many findings which you would in your usual practice do. And that is why doing the Viva practice on hot seats is so important. It prepares you for the real day. The more you appear in the hot seat, the more Vivas you give, the more you'll get comfortable to perform under pressure. This is nothing else other than pressure, okay? So I hope all the candidates are here. We will start with the first case. And one thing which I want to feedback to all the candidates and all the participants here, that it is very important that you take a few seconds of your initial Viva telling, explaining what modality, what sequence, and whether plain or contrast enhanced, okay? So I would have liked all of you to start with that these are axial images of CT abdomen pelvis done without contrast. Yeah, this is plain CT. Make it a habit. This will save you lots. So this would become very obvious that this is a plain CT abdomen. Secondly, um, it doesn't matter whether this is FCPS Viva or FRCR Viva. The rules remain the same. You have to tell the pertinent positive findings. And if at any point the examiner tells you, ignore it, ignore it. Okay? If the examiner is telling you that forget about the stomach, yeah? If the candidate says the stomach looks collapsed, I'm not sure whether there is any thickening, the candidate is right. But if the examiner is telling ignore it, this means this is not what the examiner is looking for. This is not the acute emergency. So listen to what the examiner says. In FRCR Viva especially, they will not tell you, they usually do not give you history right away. You have to earn the history. But if the examiner has given you the history, then remember it. That's vital. Okay. Similarly, in this case, once the examiner said, forget about the CBD and gallbladder, forget about it. Okay. Now, the most important thing, which I'm telling you guys, which you must have seen that I was making you guys trace the bowel, is the reason that this is very important in the Viva setting. If I trace this, if you look at the history, it said now, which I didn't tell that time, the surgery said that this is abscess, right? They did some ultrasound on the bedside and they said it's abscess and they sent the patient for confirmation. Okay. Now, if you look closely here, I know it is tough. That is why I did not press the candidate one too much. But can you see the femoral vessels here? It is pushed laterally, and this is actually a femoral hernia, which is complicated and has incarcerated. Okay, so this was a case of incarcerated right femoral hernia. So make it a practice always to trace the bowel loop, um, because that would make a lot of difference for you. Having said that, I know that tracing here was a bit difficult. That is why I will not press much further. But if you look closely, this is where the bowel loop becomes continuity. So that was one. That tell which axial images, CT abdomen, plain. Similarly, this is actually the prostate, which was indenting the urinary bladder base. Again, one said that ignore it, ignore it. So this was a case of incarcerated femoral hernia. Okay. Coming to the next case. This was an RTA, right? So when you said that this, if I can have the coronal would have made things very simple. That is why I said no, the coronal should not be given. In the exam Viva, we would expect you to trace this and say that this is, if you see, my arrow is exactly at the stomach. Yeah. And you would say that this is actually the stomach, which is the waistband. This is a traumatic diaphragmatic rupture, which has led to the stomach going up. Hmm? When you see the coronal, it would become very obvious, but that is why the examiner would insist on telling you that tell us on the axials. And the candidate did give the differential that this could be stomach, and that is why it was okay for me. But try to trace the viscous. Okay, once you trace the viscous, it would always be easier. So this was a traumatic diaphragmatic rupture with the stomach part of it going up and forming a waist. So this was gastric, the stomach moving into the thorax. Okay, this one, let me see which one is this. Yes. So again, I would have liked the all of you to start that this is axial CT, abdomen and pelvis, a plain study. There is no IV contrast, right? everything was done very nicely. I'm happy. Once you say plain CT and you see a high density, you're sure that this is hemoperitoneum. And I think the candidate did reach the fact that this is nodular and there are lesions. So HCC, always tell the common things first. That this is a plain study. My evaluation is limited, but considering that liver morphology and the multifocality, HCC would be more probable to bleed and cause hemoperitoneum. Okay. Again, this was done quite well. I'm happy with it. But just say, always mention that you are talking about the that this is a plain study. This is something which I did not show, but this was a DSA done by the IR team, and this was an HCC which showed that there were active cause of the bleeding here. Okay, this one, this is again A&E. You see, the reason I was putting these CT brains is that in the exam, once you say that I'm looking at the CT brain, but when a patient comes from the A&E with neurological deficit, I would like to see the image in stroke window. And that would make any examiner very happy, right? And he or she will immediately give you the stroke windows, not stroke windows, will tell you, yes, you can window your window change the settings of your windows. Yes, because in FRCR2B you can alter the window, or the examiner will change it for you. Once you alter it, I think as the candidate told us, there is right-sided subdural hemorrhage, very obvious. There is the subarachnoid hemorrhage, very nicely told. She also mentioned the hematoma in the frontal, and this was the, and I think I do remember she told about the tentorium cerebelli as well. See, so all these things have been mentioned, and I want all the candidates, all of us should be saying it in the beginning, that we are looking at the CT brain for a patient with neurological deficit. I would like to scroll it in the stroke windows, and things would become simpler. Okay, let's go to the next one. I think here it was the candidate 2 which started. So I deliberately did not give the history. And if you see, as the candidate told us, that there are burr holes. So this is what the
Sorry,
exam.
we can't see the next case.
Okay, let me. Yeah,
Yeah,
thank
now
you
we
for
can.
telling that. Yeah. So immediately, this is always a good habit when the candidate told that there are burr holes. This means that a neurological intervention has already been done. So the patient already had a subdural hemorrhage evacuation, and the patient again had, sorry, second episode of subdural hemorrhage. The only thing I'll say here, once you have told that there is a subdural hemorrhage, it is causing mass effect, midline shift, subfalcine herniation with the pressure effect, with the mass effect on the right lateral ventricle. Do not go into further details that I cannot see the frontal horn, I cannot see the occipital horn. You are losing your time. You have picked up all the good findings. You have summarized it. You're good to go. So after describing the findings, you say, I'll immediately pick up the phone and tell the neurosurgery that there is again a demonstration of the subdural hemorrhage with previous evidence of evacuation. That is all. Once you have wrapped up the case, try to finish it so that you can go to the next case, which does not mean that I want you to hurry up through every case. Every case will take a different time. What I mean to say, once you have picked up the finding, try to summarize your what you're saying in the Viva, and try to finish the case as quickly as possible. Okay, now this one. Okay, let me try to trace this. I was very happy with this case in the sense, if you remember, I told that the patient has drop in hemoglobin and the candidate forgot the history. And then I said, I will not tell you the history. Now you deal with it. But the candidate immediately picked up this contrast splash, which increased in the portal venous phase. Yeah. So let me try to see if I can trace the colon here, because I felt that it should be traceable, and for us to tell that this is not the colon. But at times, It might be difficult, but let me try it. So I'm still in the colon on the left side, right? And then I have come to the transverse. And at this point, I do understand that it becomes difficult to trace the colon. It somehow gets lost. Yeah. So if the candidate is saying that transverse colon, I will not be very mad. I can understand that. But then in the angiography, it was very nicely picked up that SMA and jejunal, and there is a blush. I was happy that she scrolled through the images and always try to look at whatever annotations you have in your study. So this shows that you are paying attention, and if you're lucky with hints, why not? So SMA post embolization, and we saw that it was embolized. So it was basically a jejunal loop, which was showing that bleed, and it was embolized by the IR. Yeah. So this was a very good case here. Okay. Now this one, yeah, this one was a tough one. This CT abdomen, this CT brain, I do realize was a tough one, but then that is why I was constantly giving hints to the to the candidate that the patient has neurological deficit on the right side. So if you would bear with me, can you see the extraaxial CSF spaces, the Sylvian fissure on the other side? So this is the MCA dot sign here, very subtle. I will not be very surprised if it's difficult to see, but retrospectively, now you can appreciate it, that there is left-sided MCA dot sign, okay? And then I gave the next day. Now here the MCA dot sign is not very visible, but there is subtle attenuation in, look at the cerebral hemisphere here and look at the cerebral hemisphere there. So there is subtle low attenuation. So the main point here was to find this dot, MCA dot. It's just to remember in the future. I know it's tough. There is no penalty for it. We all will pick some, we all will not pick some. That's fine. After that, the candidate 3 came up. Now here again, what I feel is all of you should be a bit, for all of us, that be systematic. I'm very happy with how with the Vivas went, but this is just for improvement, yeah? So once you have localized that what the finding is, where the pathology is, concentrate there, and always trace the colon. Now look, this is the rectum. You guys can see my arrow, right? So rectum, and then we have this looping sigmoid, yeah? Sigmoid, sigmoid, sigmoid. And then when we see all this heterogeneous density and the air, yeah? And what is happening here, this looks like fecal matter. Now, the examiner here is helping you out by saying that there is no diverticular disease, there is no tumor here. So what we are trying to get at is that there is perforation, which the candidate rightly pointed out. There is free air, yeah? You can see even here, although this is not lung windows, but you can see that these are the air foci which should not be there. So this is pneumoperitoneum. So this is an example of stercoral perforation. You know, when the rectosigmoid is loaded with fecal matter and there's a stercoral colitis, this can also lead to stercoral perforation. So that is what this case was. But well done. And I'm very happy when all of you guys are saying that in our routine practice, I look at the lung windows. In my routine practice, I look at the bone windows when a fracture is coming up. This tells the examiner that how you are approaching your reporting on a day-to-day basis. So this was a case of stercoral perforation. Now let me go to the next case. So again, this case was very well done. I was happy by how, again, in this case, you guys said that we look at the bone windows. Although you were giving me findings on the soft tissue windows, but saying that was very good. And you said that there is maxillary sinus, ethmoid sinus, you know, destruction of lamina papyracea, subperiosteal abscess, and you went on to look at the orbital apex and the intracranial, which tells the examiner that you know what to look for when you see such a case. The aim of the Viva is whether the candidates can be um, can go into the radiology field as consultants making independent decision. So they are more interested how you're approaching the case rather than your final diagnosis, right? Because final diagnosis is not always straightforward case. So this was very well done. And once you said I'm looking at the intracranial, I said okay, that's fine. That is all I needed. And then what is the next step? Okay, for the next step, never wait for the examiner to ask you what to do next. Okay, this is I'm saying in general. I'm not saying that all of you did it, but in general. And now in this next case, what I want you to know that the examiner needs to see that you are treating a patient and not a imaging. So this was excellently picked up. I do understand how it was approached, and you very rightly said that you can see the hyperdensity anteriorly, and so this was a leaking abdominal aortic aneurysms. Yeah. But what I just needed was more urgency. Yeah. This is an actively leaking abdominal aortic aneurysm. I would immediately call the referring clinical team. I would involve IR radiology, whatever. What we need is that they have to go in because this is actively leaking. No time to do the diagnostic angiography. What we need is something to fix this. That is all I have to say. Otherwise, this was brilliantly picked up and adequately described. Let's go to the next case. Yeah. So this was basically to show the day-to-day scenario that the surgical team and the consultant will call you, or they come up with your clinical team and say, oh, this for us, the patient is not acute appendicitis. So as a radiologist, you should be confident when there is acute appendicitis. And as the candidate was telling, is there any doubt that this is a blind ending loop? Is there any doubt that this is a blind ending appendix thickened and an appendiculate with all the inflammatory changes in the right iliac fossa and the midline pelvis? So no matter how much pressure the surgical team comes and tells you this is not appendicitis, you stay firm and you say, I have seen the CT abdomen and this is appendicitis. I cannot tell you of anything else. So this was just to recreate those scenarios that there can be cases when it's dubious, where there is appendicular mass or there is right-sided colonic changes, and you're not sure whether this is due to IBD or this is appendicitis. But in cases like these, when the appendix is clearly visible, plus an appendicolith, you say this is appendicitis radiologically, period. Yeah? Okay. Now, I think here the next candidate started, and very happy with how it was done. The very important thing to tell about the depressed fracture, which makes it a real acute emergency to go and involve the neurosurgical team urgently. Don't say extradural, this is subdural, which you rightly said later. Yeah. So this was well done. After this, what did we have? Yeah. So this is the one in which I started with the X-ray. What I wanted to say, you said it very nicely that you can see the history. So what I wanted.
Sorry for interrupting. Could you reshare the screen?
Oh, sorry. Yeah. Thank you for letting me know. So this is the abdominal X-ray, and you told me about the dilated colon, left-sided. Yes. Or if the examiner presses you further, what I wanted you to say that I cannot see the air distal to the descending colon. That's all. If you would say that, that would make the examiner very happy. But the fact that you said that I can see the dilated colon and the small bowel is good. But this would just get you the brownie points. That suddenly there is tapering off of the air in the left-sided colon after the distal part. Yeah. Now, if I go to now here, I can totally understand because in our daily practice, we are using the axials, the chorals, and sagittals, right? But in the exam settings, especially, they do not tend to give you coronal and sagittal unless and until they really have to. So, for example, here what I needed the candidate to do, which the candidate did, is trace the left-sided colon, because you can see that there is dilatation of the large and small bowel. Your next target is to find where the obstruction is. And as you trace it, You found this mass thickening and you found this stranding, and you very rightly said that I'll be suspicious for the mass. Now, the only thing here which I would say is this: the patient is in obstruction, not only of the large bowel, but also the small bowel. So at the moment, the first priority is the surgery to go in and defunction the patient. Yeah. Otherwise, we cannot go for the colonoscopy at the moment. What this patient needs is first surgery, defunction, and then it will go to the colonoscopy and the biopsy and the staging. So this is the only thing which you should remember, that when it should be an emergency and when it should go to the colonoscopy and for the oncology point of view. Okay. This one again, this was a tough one, but I'm happy with how the candidate proceeded. She picked up that the patient is pregnant. She picked up that there is this hemorrhage. And you were very right in saying that I'm thinking of hemorrhagic infarct. And I do understand in the plane it's difficult. So you were saying that the sigmoid and the transverse is doing. So your way of thinking was correct. Yeah. Now, immediately what you should see here is that this is post contrast. And the other thing which I wanted you to see, that this is a young patient, right? There should not be any white matter ischemia. But if you see now, there is interval development on the left side as well of the hypodensity. So this was actually supporting what you were saying all along, that now 24 hours later, there is an area of hypodensity in the left cerebral hemisphere as well. So there is bilateral infarcts now, which makes me more suspicious that these are venous infarcts. The reason I gave you the coronals is because it was tough to see it in the axials. Now, usually when we are seeing in the venograms, we should be able to appreciate the filling defects, right? So it was not the transverse sinuses. It's basically, if you keep tracing the superior sagittal sinus, you will see it's opacified and then it has a filling defect. Yeah. So this was actually, again, we have filling defect. Again, filling defect. So this is sagittal sinus thrombosis, a tough one to pick up, but worth keeping in mind. But this was, as you initially thought, this was a venous infarct all along. Okay. So this is all the feedbacks of the cases of the Vivas you gave. I was very happy with how the candidates approached. You all kept talking during the Viva, trying to find out, and that is what's important. Just remember the basic things. Point out whether it's plain, point out whether it's post contrast. The rest of the things you are doing fine. Is there any question anyone wants to ask, please?